Welcome to the final explainer in our four-part clinical series on vestibular migraine rehabilitation. We've already covered the diagnostic criteria, mapped out the lifestyle pillars, and established why cautious habituation is so absolutely crucial. So today, we're bringing it all together to look at the end game, securing those life-changing, long-term results for your patients. Let's dive right in. This explainer is based on the literature review Vestibular Migraine Rehabilitation Approaches, Diagnostic Criteria, Lifestyle Pillars, Cautious Habituation, published by Australian Dizziness Clinics. You can find all of this available at australiandizzinessclinics.com. All right, let's start right at the bottom line. A brief 6-week block of standard vestibular rehabilitation therapy, it rarely closes a vestibular migraine case. Actually, if you try to rush it, you're probably just going to flare your patient's symptoms right up. But when you use the right long-term multidisciplinary approach, 60 to 70% of patients see substantial improvement at 12 months. That is a massive shift from where these patients usually start. And it gets even better when we look at the longer-term horizon. Looking out to 24 months, 30 to 40% of patients achieve near remission. We aren't just talking about a slight reduction in dizziness here. We are talking about completely transforming their lives, getting them back into busy grocery stores, driving, and working without that constant, terrifying fear of a debilitating episode. It's a real game changer. To actually hit those fantastic statistics, we've got to understand the foundational pillars of long-term success. So today, we'll quickly map out this journey across long-term outcomes, the prophylaxis ladder, the co-management triangle, referral rules, and then our series wrap-up. So, Section 1, Long-Term Outcomes. Let's break down exactly what factors push a patient towards success and what holds them back. The trajectory of recovery depends heavily on a few key prognostic factors. Patients dealing with things like a really high dizziness handicap inventory score, comorbid PPDD, severe anxiety, or a perimenopausal hormonal pattern, they definitely face a tougher road. Delayed care is another big roadblock. But the good news is we can actively tip the scales towards success. How? Through early diagnosis, super strict adherence to those lifestyle pillars, making sure they tolerate their prophylaxis, and running a carefully structured, cautious dose rehab program. Which brings us to Section 2, the prophylaxis ladder. We have to look at the medical side of things here. Because physical rehab in vestibular migraine absolutely operates best on top of a solid pharmacological foundation. You simply cannot out-exercise a brain that's chemically locked in a migraine cycle. So knowing this prevention ladder is critical. Step 1 includes your standard options, beta blockers like propranolol, blood pressure meds, topiramate. But if those fail, Step 2 brings in the heavy hitters, the CGRP monoclonal antibodies. Drugs like erinumab and galcanezumab have literally revolutionized VM prevention over the last 5 years. Even though we aren't prescribing these as physios, knowing exactly where your patient sits on this ladder is essential. And that brings us to my absolute favorite clinical pearl. VRT in vestibular migraine works best when prophylaxis is optimized. Listen, the medication is the lever here, not the exercise. If a patient is constantly flaring up from triggers or your VRT, they need their meds optimized before you even think about escalating their physical rehab dose. Pushing harder, it's just going to cause a symptom flare and lead to patient dropout, for sure. Okay, moving on to Section 3, the co-management triangle. This perfectly illustrates the undeniable link between medical prevention and physical therapy. Optimal care is never a solo job. It's like a three-legged stool. You've got the physiotherapist on one side, the vestibular physician on the other, and the patient right there in the center actively tracking their triggers. All three of you must operate in total synchronization. If one side of this triangle breaks down, say we forget to communicate a rehab plateau to the physician, the entire recovery process just stalls out. So establishing clear boundaries within that triangle is absolutely vital. The vestibular physician completely owns the medical sphere, prophylaxis selection, dose titration, hormonal reviews, and escalating those tricky refractory cases. Meanwhile, you, the physiotherapist, own the behavioral sphere. You're deeply educating them on triggers, keeping them accountable to the lifestyle pillars, administering that cautious VRT, and rigorously tracking their outcomes. To keep these well-oiled machine running smoothly, you need strict communication timelines. Early on, initiate joint reviews with the physician every 6 to 8 weeks to cross-reference their VRT tolerance with any medication side effects. Then, once the patient is stable and making a steady upward climb, you can shift to every 3 to 6 months. It's all about catching someone before they fall off the wagon, All right, Section 4, referral decision rules. Because, let's be real, things don't always go to plan. Knowing exactly when to trigger that joint review or escalate a case is a non-negotiable skill. You must escalate the patient back to the vestibular physician immediately under a few specific conditions. First, if they're having more than 4 episodes a month despite strict lifestyle changes. Second, if their DHI score is stuck over 50 after 12 weeks. Third, if their prophylaxis is clearly failing or they just can't tolerate it. And lastly, if any new neurological features suddenly pop up. You cannot sit on these cases. Early escalation is the true hallmark of a great clinician. Finally, Section 5, our series wrap-up. Let's zoom out and crystallize this whole framework. If you take absolutely nothing else away from this entire 4-part explainer, let it be this. Vestibular migraine rehabilitation must always be dose-cautious. It must be strictly lifestyle-led. It has to be powerfully prophylaxis-supported. And finally, it must be expertly co-managed. When these 4 elements perfectly align, you aren't just treating dizziness, you are literally giving patients their lives back. So take a second to think about your current caseload. Who is the very first patient you need to implement this new framework with tomorrow morning? For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this video series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. Thank you so much for joining us on this deep dive. Keep learning, keep collaborating, and we will catch you in the next explainer.